What happens when your doctor says three words nobody really wants to hear? You need surgery.
Ugh. So, what do you say, Nancy? Do you say yes? Sure, go ahead. Do you say get a second opinion? Or do you wait? And how do you even know if you're making the right decision? It's a
Well,
lot.
today, Eleni, we are taking some of the fear and the mystery out of surgery and giving you the questions you need to ask before you ever entertain or enter an operating room.
Welcome back to Deep Diving Divas. I'm Elaine Duran,
And I'm Nancy Fox.
and we have the perfect expert to help us dive into this today. Dr. Neel Joshi, a highly respected general surgeon at Cedars-Sinai Medical Center in Los Angeles.
Now, Dr. Joshi received his undergraduate degree from Princeton and his medical degree from the Mayo Clinic Medical School. And he's been practicing at Cedars for over 17 years and serves as the vice chair for the Department of Surgery at Cedars-Sinai. And get this, if that wasn't enough, he also is an associate clinical professor of surgery at UCLA.
So, when it comes to understanding surgery, even if you don't want to, from deciding whether you really need it, how to prepare for it, and how to recover from it, we could absolutely not think of anyone better to ask and to trust.
And Elaine, you know this, but none of you do. I have another reason I wanted to share Dr. Joshi here. He was my surgeon. I had two different hernia operations with him in the last couple of years, and he's the best surgeon. And since hernias are so common in both women and men, we're diving into those too.
And because if you or someone you love ever needs surgery, any kind of surgery, we want you to know what questions to ask. That is really the most important part of this episode, and how to advocate for yourself.
Hey there, friends, it's Nancy and Elaine. They're the Deep Diving Divas, it's quite a name. They're diving deep into the things that matter most, from friendships to family and so much more. Join them each week for a splash of fun.
Dr. Joshi, welcome to Deep Diving Divas. We are so delighted to have you here.
Thank you so much. It's my pleasure and an honor. Thanks for the invitation.
Oh, it's great. It's so nice to meet you, doctor.
So I know you as a general surgeon, but what exactly does that mean when it's talking about you? Because you do all kinds of surgeries.
So general surgery training encompasses a lot of head to toe training on surgical pathology and disease that affects many different organ systems. And so during a 6-year general surgery residency program, a surgeon gets trained and becomes relatively expert in a lot of different areas, such as oncologic surgery, gastrointestinal surgery, to name a few. When I started in practice in 2009, I had a very, very broad practice that encompassed a lot of the different disciplines in surgery. So I did a lot of cancer surgery for conditions like breast and colon cancer, a lot of emergency surgery, as well as a lot of elective operations like hernia repairs and things like that. As the arc of my career has taken off, and as I've had the ability to narrow my practice in order to make it more sustainable, I've narrowed my focus now to include a lot of abdominal wall hernias, a lot of robotic and laparoscopic, minimally invasive surgical approaches to treat abdominal conditions. And most recently, my passion project for the last 5 years, which has really become a really fun niche, is taking care of professional and college athletes with quote unquote sports hernia or core muscle injuries in the abdominal wall. And these are very nuanced operations that only a small group of surgeons around the world really get these referrals. And I've been fortunate over the course of the last couple of years to take care of 2 Olympic gold medalists, 3 athletes who took part in the World Cup that recently took
Wow.
place here in the United States, and it's been a really really fun part of my practice that continues to grow. So I feel very fortunate that I've had the experience of taking care of so many patients with such a wide variety of conditions. But it is much more manageable and sustainable now that I've narrowed my focus.
Makes sense.
Did you get to go to the World Cup?
I did.
Oh, you did? I was going to say they probably had you on the field there just in case.
I did. You know, one of the most rewarding things, about my practice with the athletes is that they're actually some of the nicest and most down to earth people in terms of your patients, and they really come to view you as a member of their team. And so, I've maintained relationships with these athletes. I get text messages after the game thanking me for how good they're feeling and how well they're playing. And I have a text message from one of the Olympic medalists who actually sent me this incredible video of him holding his gold medal from Cortina the night that they won the championship. And so super rewarding. And yes, as someone who's always been a lover and enthusiast of sports, getting to interact with players and teams and agents and getting to go and spend time on the sidelines and in the locker rooms. It's been like a dream, honestly. It's
Wow.
like a childhood dream come true. So I feel very fortunate.
We want to start with the moment that so many people absolutely dread. You walk into a doctor's office and you hear them say, "You need surgery." I mean, what is the very first question you want that patient to ask you?
Yeah, even as you describe that scenario, it reminds me of something that one of my mentors in surgery told me years ago, in kind of describing how kind of sacred and stressful this type of moment is for a person. We were going through an operation, and the patient was very stressed as they were going under anesthesia, and it was for a relatively minor procedure. And after they went to sleep and we started the case, the surgeon turned to me and said, Neel, remember that for most people, having an operation is probably one of the 5 most stressful times in their entire life, right? Right up there with, an illness, a loss of a loved one. It can be a very significant and stressful moment for people because, there's such a loss of control, and it can be such a black box in terms of not understanding what the risks are and what what the different factors are. And happy to be here today to shed light on it. I think the best kind of message is that here in 2026, having invasive procedures and surgery means something very different and very much better than it used to mean. The medical science and surgical science have advanced so much, and we now have the ability to get people through pretty invasive procedures using tiny incisions and doing anesthetic blocks and monitoring them in ways that procedures that heretofore had been very dangerous and scary are now much more routine, and the outcomes tend to be much better and safer. With that said, when a person is told they need to have surgery, I think it remains a very stressful time. And I think the counseling really starts at the moment that the person who's referring them to see a surgeon meets them. And I think it's why it's so great to have a well-informed primary care physician or internist or gastroenterologist who refers to a surgeon, because they can help to demystify some of these stressful factors for patients. But once a person is told they need to see a surgeon, which is usually the thing that precedes the decision to have surgery or not. That's when a lot of the research happens. Especially here in our community in Los Angeles, we have very well informed patients who ask around. They do Google searches. They look up people and find out. And very often, by the time they come and see a surgeon like me for whatever condition they're coming for, they're already relatively informed and at least know some of the lingo, know some of the anatomy and some of the issues.
If I could just stop you right there, because there was something on the news last night. Of course, what I'm going to bring up is the whole AI issue, because they said that so many more people, are going to look at AI, not even Google anymore. That's kind of like old news. And that, and that, as we all know, it can be correct. It might not be correct. I mean, how has it affected you in having to, if someone's come in and read something and you don't feel that's the right thing to do, or you would not suggest that?
Yeah, I actually enjoy having informed patients. I think, again, the danger is if the information that they've received is inaccurate or potentially misinterpreted. I think, when people come and start describing things, I let them talk, first and foremost, because sometimes it's cathartic to kind of get out some of these messages and some of the things that they've read. And then once they're ready to then kind of have a nuanced discussion, I think the first thing that I mention to them is that, information is great, but you have to contextualize it, right? You have to actually understand how, what you've read, how that has an impact in the context of your own body, your own condition. The surgeon who's going to decide whether to do surgery, what factors he or she is considering when deciding what to do. And I think importantly, the biggest thing is to not view information in a vacuum. Sometimes people say, I don't want to get my hernia fixed because I heard it really hurts a lot. And okay, fair enough. That can be true once in a while, even though we've gotten better at it. I think what I often will respond with is, remember that the condition, the hernia, can become much more painful and much more dangerous. And by avoiding a relatively safe and thoughtful intervention, you're actually putting yourself at risk for much more pain and much more disability moving forward, right? So it's not a balance in a vacuum of, I'm either having the surgery or not. And if I don't have surgery, I'm fine. The reason that you're contemplating it in the first place is to try to solve a solvable problem so that it doesn't become a bigger problem down the line. And similarly, when it comes to nuance with any operation, people often have read things on the internet in relation to complications and things. And when that happens, and I appreciate that they're informed, I try to bring them back to kind of the gist of why they're here. Yes, you can end up with a potential complication, but the incidence of a lot of these things is extraordinarily rare in relation to the likelihood of success. And again, if you have a surgical condition, very often not performing surgery in a timely fashion allows a very solvable problem to turn into something that can be much more problematic. And very often when pathology is neglected and people delay receiving care for solvable problems, by the time they actually end up having the care, sometimes it's no longer as effective, or they're just not in a condition to be able to have as good of an outcome as they might have had it had they been more proactive. And so a lot of the conversation with my patients is not only introducing the idea of what their disease condition is and why surgery is potentially beneficial, but also kind of a balanced, nuanced discussion about, here's what happens if you have surgery, here's what happens if you don't have surgery, and this is why you might choose door number one over door number two, because in the long run, you're going to be better off.
Well, by the way, that's so meaty, and so many things have come to mind with what you just shared. Number one, you know, uh, my husband and I have come to the conclusion, the older we get, if you're healthy, or if even if you're not healthy, but if you're healthy and you need something fixed, repaired, do it now while you can do it while you're healthy, while you're physically active, whatever, because I'm assuming, but maybe I'm wrong, maybe the outcome and also the recovery might get easier. Do you agree with that?
Yeah, so it is true. I mean, I would say it's more true for certain conditions than others. Hernias, which is an area that's one of my specialties. Certainly, fixing a hernia when the hernia defect is small and the patient is younger and healthier portends a better long-term outcome, because the tissues are more healthy, the person's ability to tolerate surgery is better, the hole itself is a smaller hole. So if you wait and all of a sudden now you're 10 years older, your tissues are weaker, the problem has gotten bigger because the hole is bigger, now all of a sudden the long-term success might be less. The amount of pain and disability that happens from the operation itself might be more. On the other hand, there are operations like, for instance, joint replacements. That's one that comes to mind. I'm not an orthopedic surgeon, but as someone who works in sports medicine and works hand in hand with a lot of orthopedic surgeons, I know many times that patients who have arthritic changes in their knees and hips are kind of told by their orthopedic surgeons that you ought to wait as long as possible prior to having, say, a joint replacement, because the joint replacement itself has sort of a duration of success, and kind of a window, through which you can expect to have relief, and if you have it done, very, very young, what you're basically kind of predisposing yourself to is the need to have a second joint replacement done again, when the initial implant wears out, or whatnot. And so there are certain conditions where you might want to wait, but by and large, for most surgical pathology, you're better off being proactive. And I think one other point to make, I think it goes back to what I'd said initially about how surgery and medical science have advanced so much. I think 40, 50 years ago, when a patient came to their primary care physician and were found to have, say, a hernia, something that's a correctable surgical condition, the party line back then was, well, if it's not bothering you, leave it
Right.
alone, right?
I
Just leave it alone, because it's not bothering you. And really, the second half of that, which was sort of the unsaid part of the message, was because surgery is really unpleasant, and it's dangerous, and it's going to hurt, and you could
Yeah.
get an infection, and you could have all these things happen, right? And all that was true, right? And I mean, look, there was a time 100 years ago, before antisepsis, where when people had operations, surgeons wouldn't even wash their hands, much less give
Oh
them
my goodness.
antibiotics, which didn't exist. And so people 100 years ago could go in for minor procedures and die of sepsis, right?
Yeah.
And so if you kind of fast forward from those rudimentary times to what we do today, so much scientific advance has happened, where a lot of the things people were very fearful about before have been rectified. As an example, anesthesia is so much safer today than it was many decades ago, because our anesthesia colleagues now are able to do continuous monitoring of all the different hemodynamics. Surgery now is now done very often using tiny incisions and laparoscopic or robotic techniques, or things that are done where people bounce back quickly. I mean, for most of the patients who I do surgery for, they don't even require any narcotics at all after surgery. They just take
Really?
Tylenol or
Right.
ibuprofen.
But let's talk about hernias for a moment. I was your patient not once but twice. Not because you did a phenomenal job
You had
with the
such a good
first. I
job. You gotta
developed
go back.
I developed a hernia in another body part. So what I want to know, for first of all, and I did not take any narcotics. You have the magic touch. That's how I
Thank you.
contributed. The surgeon, it's a lot of it's how, look at their hands. Are they gentle? but I'm just teasing. But with that in mind, what exactly is a hernia? And why do certain people like me, I've had four over my lifetime, in different body parts, an umbilical, a groin, and then one sort of in my abdomen. So what is it? And why do some people get more than others?
So hernias are among the most common surgical conditions treated by surgeons around the world. And the simplest way to think about a hernia is a hole or a defect in the abdominal wall. There are other types of hernias. The term hernia is used in other medical parlance, like people will talk about a herniated disc in their spine, or a hiatal hernia, which is a hernia in the diaphragm. Those are different, but most of the time people are talking about abdominal wall hernias, which is really the area that I focus on. And there are a couple of areas in particular that are very prone and vulnerable to hernia development. And a lot of it hinges on embryology and how we develop in utero. So when all of us were still inside our moms developing before we were born, there was an umbilical cord that connected us to our moms, and that's how we were able to get nutrients, and waste products were able to go out through our moms. Obviously, when we're born, the umbilical cord gets clamped, and then that area nicely kind of fuses up, but it remains an area of relative vulnerability where either early in life or later on, people can develop hernias. So it's not uncommon for little babies to be born with hernias. More commonly, people as we age can develop hernias, specifically in the belly button area, women who have children and undergo pregnancy, as the uterus gets big and pushes on the abdominal wall, that can create a little bit of force, which can then cause a disruption of the fascia and result in a tear or an opening there. So belly button or umbilical hernias are very common. The other area that's very common is actually inguinal or groin hernias. Those are much more common in men than women. Something like 27% of men will get an inguinal hernia at some point in life. Only 3% of women. So lucky you, Nancy. You were in the 97th percentile. But the reason why men in particular tend to get groin hernias is, again, it goes back to embryology and fetal development. During fetal development in males, the testicles start off inside the abdomen, and they have to descend into the scrotum through holes in the abdominal wall. So those openings in the abdominal wall that allow for the descent of the testicles during fetal development are the area of vulnerability where either early or later in life, boys and then men can develop hernias. And we see these again in infants, which are treated by pediatric surgeons. And I've done operations in men in their 90s who develop groin hernias. Now, women can get these too, the way that Nancy did, and the structure that kind of predisposes women to developing groin hernias is called the round ligament, which is a suspensory ligament that holds up the uterus, and that courses through the abdominal wall the same way that the spermatic cord does in men. And sometimes that sort of vulnerability and that opening in the abdominal wall can dilate and result in the presence of a groin hernia. So women definitely get groin hernias. 3% of women get them, which is much less than men, but 3% of a big population means that I'm very busy seeing lots of women with groin hernias and fixing them all the time.
Well, let me ask you something. And you're talking about all of the updates and the miracles of modern medicine, but sometimes people don't want to hear you say you need surgery. And I know some of my friends will do this. They will keep going. They will keep getting second, third opinions until they get the answer they want, which is you don't need to have surgery. And then when they hear that, it's like, okay, that's it. It didn't make any difference. So how do you feel? I mean, what is it like, as a doctor when someone says, I'm going to get a second opinion, or you've heard it through the grapevine kind of?
Yeah. So I'll address the second opinion part first. It's interesting because the way my practice has evolved, part of it is working at an excellence center like Cedars-Sinai. We get a lot of second and third and fourth opinions of people who are sort of dissatisfied or unhappy with what they've heard from their local physicians or even other physicians in the community, and they say, you know what, I want to get a second opinion. I've heard through the grapevine that Dr. Such and Such is a good person to see, and they'll come for that. I think if you've got the time and the resources to get a second opinion, it's never a wrong decision because it's just information, right? And I think sometimes, especially if you're uncertain about what the best pathway is in terms of moving forward, it can be helpful and reassuring if you get a second opinion and it either reinforces what your first physician or surgeon told you, or if the message is very different, then it highlights to you that maybe it's a little bit more controversial than your first physician might have made you feel. Now, with that said, I think going back to the issue about whether to do surgery or not, I like to think about surgery in terms of three categories of conditions, right? And I think there are the true emergencies, right? If a person comes in to our trauma center at Cedars-Sinai with a gunshot wound to the abdomen and they're, in extremis, nothing short of an operation is going to save their life, right? That is not a decision, right? They're not even allowed to make a decision. They're brought in by ambulance and they go right up to the operating room, and our amazing trauma surgeons take care of them and save their life. Then the second category would be things that are, kind of more urgent, right? Like cancers, for example, that, and there are cancers where your primary modality might not be surgery and you do chemotherapy first or something like that. But for a lot of cancers, especially early stage cancer, surgery is the tried and true method to cure them. And so, yes, they are not emergencies per se, in the sense that you have to run to the emergency room to have a breast cancer removed or a colon cancer removed. But there is urgency, and the data suggests that anything short of surgery for some of these conditions would really not be appropriate. It would be kind of a departure from the standard of care. The third category, though, would be some of the things that we're talking about right now, the things like hernias joint replacements, and things where there is kind of increasing disability given more time. A person's quality of life is really being impaired by the fact that they've got this treatable condition that is limiting their ability to, say, exercise or dance or play golf or mountain climb or whatever it is that provides them with satisfaction and quality of life. And so, we use the term elective surgery. I think, sometimes people get almost a little concerned when I use the term elective surgery, because I think they think of that and they think of like cosmetic surgery or something that's not really necessary. I remind them that elective surgery means that you can choose the time to do it and choose a convenient time. It's
Oh,
still medically indicated, right? It's not something that you're just doing willy-nilly. It's medically indicated, but it's something that can be scheduled at a time and place that's convenient for the patient, and for the surgeon. And I think, depending on which of those three categories of surgery that you're talking about, I think the approach is very different. And, because again, if somebody who, say, has a cancer is reluctant to have surgery, I think, the surgeon and the physicians taking care of that person have a real responsibility to try their best to talk them into doing the right thing. Because if they don't, the outcome is going to be poor, and it's totally unnecessary and avoidable. When someone has, say, a hernia that's not bothering them that much, or maybe just a little, it's a little less serious. I mean, if they truly don't want to have the operation done, you still are obligated to inform them about what the natural history is like and what the trajectory moving forward is going to be like. But it's not quite as sort of negligent or harmful to them if you don't convince them, to have it to have it done. And so I think, depending on which of those categories, I think the approach taken by the surgeon, has to kind of, be modified. But, back to the point about second and third opinions and things, I think by the time most people come to see me in my office, it's because they have a treatable surgical condition and they want it treated and they want it
yeah.
fixed.
That was
Right. And,
me.
and,
Yeah.
and I think the challenge then is, if you go and see a surgeon who's in demand, very often that surgeon may not be available to finish and to fix your operation or do your thing in a time frame that you would ideally want. And that can get frustrating for both the patient and the surgeon. It's great to be popular and everyone likes to be in demand, but if someone has a solvable problem, I don't like the idea that they're going to wait 6 or 7 months till my next availability when they could get done by one of my partners or a great surgeon who's got earlier and sooner availability. And so I try my best, especially when people are really symptomatic, to try to steer them, that way, and say, listen, I've got partners who are amazing. I would let them operate on me any day of the week. They're very talented, and one day when they're as old as I am, they too will have 5 and 6 and 7 month waiting lists. But it's interesting because, I think, I came from Minnesota. I was at the Mayo Clinic where, the people are wonderful here and there, but they're very different. In Minnesota, my experience at Mayo was people were very deferential to their physicians in the sense that it's whatever you say, doctor. I trust you. I trust the Mayo Clinic. In Los Angeles, it's more of a negotiation, and it's almost like the
That's
restaurant.
funny.
If you call the restaurant and they don't have any availability, it makes you want it that much more, and
Oh
you
my
almost start to
God.
obsess about it.
How can someone get ready to have a good outcome for surgery? What should they do before surgery? And what about the aftercare?
So to the extent that a person has modifiable factors that could adversely affect the outcome, things like smoking, being significantly overweight, uncontrolled diabetes, intervening and improving those parameters would portend a much better outcome after surgery, and especially for elective operations like hernia repairs, joint replacements. It really will help to optimize a person's health prior to putting them through an invasive procedure. So we try as much as possible. Now, once in a while, a person is so symptomatic that you just are forced to do the surgery in less than ideal circumstances, in which case you tell
Mhm.
the patient after surgery, you need to really, really work on things like your diet, weight loss, and management of diabetes, certainly stopping smoking.
That makes sense. And then what about after? How can they ensure that they're recovering well? They have a quicker recovery.
So among the most important things the person can do is to first follow your surgeon's instructions when it comes to lifting and
Yeah.
exercise and activities. I love the fact that so many of my patients are fitness enthusiasts and pro and amateur athletes, but I have to really caution them to not overdo it right after surgery, and in doing so risk causing complications and trauma that could then compromise their ultimate outcome, because their goal is to really be back at full speed at 6 weeks after surgery. So another really important factor in recovery is how to manage pain, and I think to that end, I'm a big proponent of minimizing and avoiding narcotics when possible. I do a lot of things during surgery, like nerve blocks and administering medicines like intravenous Toradol that can allow patients to avoid narcotics altogether, particularly following minimally invasive procedures like robotic procedures. And this has a really big downstream impact in a favorable way on their recovery, because narcotics are notorious for causing constipation and nausea and loopiness that can keep people in bed and keep them essentially immobile. Whereas minimizing narcotics allows people to be ambulatory and up and active soon after surgery.
Dr. Joshi, there's such a huge population out there who wants to know how to get to the right doctor. Some of us are able to do it through contacts, friends, business. What do you suggest for those people? How can they find the best service, even if they can't always provide or have the insurance for it?
Oh, it's a great question, Elaine. I think the good news in 2026 is that we live now in the information age, where information is widely available. Now you have to be careful about where you get your information in terms of sources and things. But as a starting point, there are credentialing bodies like, say, the U.S. News and World Report, Health Grades, and others that are publishing reviews published by submitted by patients, and so that's a decent place to start if you're truly starting from scratch. The other thing to do, I think, is if you're able to, if you go to reputable institutions, like in a place like Los Angeles, the ones that come to mind as the bigger centers would be ours at Cedars-Sinai, UCLA, USC, City of Hope, and very often you can go to the websites of these institutions and read bios and read reviews. If you go to my website at Cedars-Sinai, you'll actually see 30 or 40 reviews at any given time of former patients who have actually submitted feedback, and you can get a sense of what people think. And so that's a good a good place, I think, to start. With that said, I want to be careful, because I know there are some really outstanding physicians and surgeons who work at smaller institutions and community hospitals, and not everyone is lucky enough to necessarily have health insurance coverage that allows them to come to some of the most illustrious centers like UCLA and Cedars-Sinai and things like that. And so there are plenty of really outstanding physicians in other places as well. I think some of it also hinges on kind of the magnitude of the problem. I think if you're coming for, say, care of a really advanced and rare cancer where the risks of surgery are very, very high, then it may be more worthwhile to pool your resources to come to a respected cancer center like a Cedars-Sinai or a Johns Hopkins or a Mayo Clinic, because again, for problems that are more rare, you're going to want to be treated at a center that does the rare things more often. Like everything else in life, the more repetitions, the better. The last thing that I wanted to kind of mention about this topic, though, is I think there are different things that people find appealing about their surgeons. A surgical skill is irreplaceable. If you could have the nicest person in the world, but if they can't sew and cut and tie, with precision, no amount of kindness is going to make up for lack of surgical skill. With that
Yeah.
said, I think for people who are discriminating consumers and patients in cities like Los Angeles, I think the thing that puts a physician or a surgeon over the top is the combination of the skill, reputation, and also bedside manner. And I think, I know for me personally, and for my family, my parents, my kids, my wife, when we are deciding on healthcare and picking physicians, bedside manner is really important to us, because it's a source of comfort, and I think it also engenders trust, because you know that for any of these things, sometimes things can go wrong and go sideways, and the question is, in that scenario, who would you want in your corner? And I think if you have a trusting and sort of special relationship with your physician and surgeon, it just makes you feel safe. And I think that's certainly something that I try to exude, and I try to make it a part of my practice. And so when a patient is deciding on a surgeon, I think, that should be an important factor.
Wow, I can't believe we're running out of time. We have so many questions we didn't get to, so hopefully you'll agree to come back and join us. In the meantime,
Absolutely, anytime.
thank you. If you want to reach Dr. Joshi, how can they get a hold of you? Maybe for a consult.
So the Cedars-Sinai website has a bio and all of my office information, including contact numbers and things on there. So feel free, any of your listeners, if you're interested in seeing me for a surgical condition, to look me up on the Cedars website. For more simple access, the best thing to do would be to call my office, and it's at area code 310 423 8350. And that's for my office at the Cedars-Sinai Medical Towers. I also have an office in Santa Monica where I see patients on Fridays for anybody who's interested in that. And that information is also available on the website.
That's perfect. I
Great.
I honestly I can say I can vouch for you. You're not just an incredible surgeon, you're an incredible person. You make the connection with your patients, and the comfort level. If anybody out there that's afraid to have surgery, either go to Dr. Joshi or look for a surgeon like that, like you said, that makes the
Oh,
personal connection that you care about.
That's so kind of you, and I appreciate that so much.
gosh,
It's all true.
it's
Thank
beautiful.
you.
Thank you so much for your time, all your knowledge.
My
Bye-bye.
pleasure.
Wow. Nancy, I wish I would have met Dr. Joshi before I've had a couple surgeries years ago.
So, you know what we didn't talk about? An advocate. Always bring
Yeah.
your spouse, a friend, a girlfriend, a boyfriend,
Yes.
a kid, somebody with you, because I know from personal experience, I
Yeah.
always go with my husband, but he came with me when I was talking about my surgery. It's hard to hear it when they're talking about you.
And
And
so you know
so
what I did?
bring somebody.
Yes, bring somebody. But I also, if I'm listening while Richard's there, I turn on my phone and I ask the doctor first, is it okay? I record exactly what the whole conversation is while we're
I
there.
love
Because I
that.
used to be busy writing notes, and then I was losing my spot. What did he just say? What did I do this? And
Yeah.
couldn't read my writing afterwards.
That's a great one. Love it. Everybody, if you have more questions for us, write on our wall on our YouTube channel under the episode. And we're going to definitely plan, if we can talk them into it, to get Dr. Joshi back on, because there's endless questions we could have asked. But until next time, thank you all.
Bye bye. Stay well.